probably going to hear something tonight that's a little different than what you hear in this pulpit most of the time. That's a Southern accent. So just get used to it. I don't know how to speak any other way. I want to talk about faith communities, what they can teach psychiatry. I spent much of my career as a churchman and as a psychiatrist trying to tell individuals within faith communities what we as psychiatrists can teach them. So what I'm going to do tonight is try to turn the tables on that and say, so what can church communities actually teach psychiatrists? And to enter that discussion, the first thing that has to be kept in mind is that the treatment of depression for millennia really resided within religious groups. And this is probably across many different societies, but certainly in Western societies. And so after Greek and Roman times, with the monasteries as the priorities that actually were treating depression, taking care of individuals with depression, their treatment wasn't always successful, certainly, and they certainly missed out on some of the more important issues, though interestingly, they took a more biological approach to depression than you might imagine, even though they had no real treatment for that. So just keep that bit of history in mind, but I'm going to make an assumption to start. And the assumption is that if faith communities are to teach psychiatrists something about depression, those faith communities must be true to their mission. And that is to encourage human flourishing and encourage the improvement in health and well-being of the individuals within that community itself. There have been many faith communities where that's not the case. Jim Jones, David Koresh, strict fundamentalism, isolated religious groups such as the Hutterites, and militant religious groups. None of these necessarily are what I'm going to be talking about. In some ways, I'm going to be talking about the ideal religious community, and I think some communities do closely reach that ideal, and others don't. So kind of keep that in mind as we go along. As we look at this, if you just take different faith traditions, Jewish, Islam, Buddhism, Protestant Christianity, Catholic Christianity, there basically is no evidence that there's a difference in terms of the frequency of mental illness across those different faith traditions. So there's nothing in and of itself about belonging to a particular religious group that renders protection against development of mental illness or in terms of treating or facilitating an individual. So we have to talk about characteristics of a faith community when they work well, not just participation in and of itself. Now, I'm a Christian, and I'm going to speak from the perspective of Christian faith tradition. But I think some of what I say, perhaps most of what I say, could apply to other faith traditions as well. So, though I'm not a member of these faith traditions, I can't speak from within those traditions, though I hopefully know something about them. If we kind of look at this whole issue of what faith communities can teach psychiatrists, maybe teach all of us about the care of the depressed, I'd like to go through 7 things that I believe can be taught. And within these 7 areas, I want to use an illustration. And the illustration is a man that I'm going to call Richard. Richard is somebody I know, but I've disguised it in such a way that even Richard would not know he was Richard. And the name obviously been changed as well. But I think I can use this as an example of how a faith community played an absolutely essential role in Richard's recovery from a very severe depression and being able to move forward with his life. So what are the 7 areas that I want to discuss? I'm going to list these initially, and then I want to go into them one by one. So the first is faith communities can teach psychiatrists that depression is at once biological and spiritual. In other words, faith communities take spirituality as a central property of personhood. 2, faith communities can teach psychiatrists who count symptoms that patients tell stories. Faith communities are born of stories. 3rd, faith communities can teach psychiatrists that the meaning of depression to the patient is important. It's not simply a disease such as a gallbladder. Faith communities are about meaning. What does the disease mean? Especially when we talk about depression. 4, faith communities teach how we name depression. That naming being very important to patients who suffer from depression. It's not just a diagnosis that you put on a billing sheet. 5th, faith communities can teach psychiatrists that there's a place for social psychiatry. So psychiatry was a very integral part of psychiatry 60 years ago, 50 years ago. And now it's virtually disappeared from psychiatry as we currently know it. Biological psychiatry basically reigns at the present time. But I think faith communities can teach that one's community can be the source of and a central component of healing, as well as what other biological or psychotherapeutic approaches that are taken to healing. 6, faith communities can teach psychiatrists that a critical part of the process of healing is hope and purpose. And 7, faith communities can teach that healing depression is a family affair. And by family, I mean everyone who interacts with the person who is depressed. That includes the psychiatrist, the family, the faith community, people within the workplace, and we could go on and on. All of these elements need to be recognized as part of the healing community and also potentially part of the problem that may lead to depression. Now, we in medicine have a name for this. We call it holistic care, but it actually sort of carries a sterile view. I think faith communities understand holistic care better than the medical community itself. So let's go through each of these using Richard as an example. First, depression is at once biological and spiritual. I like to think of us, and many people have used this term, we are embodied souls. And there's no room for Cartesian dualism where there's a soul out here and a body over here. But at the same time, there's no room for just a strict materialism either. Now, practitioners may be materialistic in their own view, but I'm talking about the perspective of the patient who's being treated for depression. From the vantage point of the patient, they're not just material. They have a soul. They have something going on. Andrew Solomon, who wrote The Noonday Demon, a book about depression, said when he became depressed, he found his soul. And so I think that's a very important consideration. Richard, my example, knew he experienced all the symptoms of major depression. He was a physician. And he had read our diagnostic and statistical manual. He could list all of the different symptoms. He knew exactly what was happening. But that really wasn't enough for Richard. Richard said there's something about this feeling of depression, and he described it as an emptiness that goes beyond just this feeling of meeting these potential symptom criteria. Depression brought that emptiness to the forefront, and the way he described his depression is, I have a sick soul. So just like Andrew Solomon saying, depression brought the soul out, Richard said, never having read Andrew Solomon, I'm suffering from a sick soul. The road to recovery for Richard, as well as working with professionals and getting medications and being in psychotherapy, all of which he did, was having his soul go from sickness back to health. And his faith community played a central role in that because they understood this need of Richard's to go from sickness to health in terms of his own soul. Patients tell stories. Today, psychiatrists often go through a checklist to see whether you're ill or not. And so we might say, you've got a problem with sleep, you've got a problem with appetite, are you don't have the energy that you once did, are you having difficulty concentrating? And if you answer enough of those questions positively, then you'll be diagnosed with having depression. That's not always been the case in psychiatry. There was a time, many years ago, when we didn't have the checklist. We actually had narrative descriptions of what depression was. And so in order to see whether an individual suffered from any kind of psychiatric morbidity, what had to happen was that the psychiatrist had to listen to the story of the patient. But we've gotten away from listening to stories. In the past, we might, if a person was really down, and there was no apparent reason for them being down, their story led us to believe that they suffered from melancholia and depression. If the person's story was just bizarre and all over the place, their story would lead us to believe that they might suffer from psychotic disorders such as schizophrenia. So stories played a major role in the way we diagnose. Faith communities are based on stories. There's usually a large story that is told within that community, and then that larger story leads to smaller stories being told within the community that fit into the larger story. You might think of it as kind of an upper story and a lower story, not in terms of the floor you are on the building, but sort of in terms of where your story fits. Very well-known theologian at Duke, Stanley Hauerwas, if you're in the divinity school, you know this name because he's been recognized as one of the preeminent theologians in the country. He loves novels. I know Stanley fairly well. He loves novels. One of his favorite novels is a novel called Watership Down. I'm just curious, how many people have read that novel? We've got a few here who've read it. Okay. I would recommend reading it if you don't mind reading about rabbits. Because the story it's a story about rabbits. It's a fable. But why Hauerwas likes this particular novel is because this novel is about a story of rabbits who have to leave their warren and have to find another warren, and the adventures along the way toward them finding a warren and being able to set themselves up and save themselves in their new place. But Watership Down is not just this story. All through the book, there is a larger story that's being told about rabbits. And it's a story about sort of the chief rabbit and the adventures that the chief rabbit has and how the rabbits get out of trouble. And they use that larger story in order to understand how to negotiate the individual difficulties they happen to be having at a given time. Now, certainly you can take that into the religious environment, the Christian environment, for example, and you can kind of see how that works. In other words, my suffering may be related to suffering of Jesus on the cross or something like this. These kind of relationships are talked about constantly within faith communities. And so a story within a story is a very important part of what faith communities do. Richard had a story to tell. It was a story of a failed marriage. It was a story of estrangement from his two daughters. It was a story of extremely hard work, 80, 90, 100 hours a week in search of perfection in his work. His faith community listened to that story. They did not try to explain it away. They didn't see it as irrelevant. They listened. They tried to understand it. Especially they tried to understand the pain that he experienced with his failed marriage and not being able to have contact with his daughters. What made it possible for this faith community to hear the stories that Richard told was that many different types of stories, some with equal pain, were being told within that faith community. And so stories were very much a part. If you come into that community, you tell stories. And so Richard very much fit in because he had a story to tell. Faith communities help the depressed search for meaning in their depression. I oftentimes think that depression is an emotion that is in search of meaning, because when somebody is really down, it's almost inevitable that they're asking the question, why? Why is this happening to me? Why am I suffering? And at times, the meaning is more, and other times less apparent. In other words, there may not be an ending to this particular story. A community that can tolerate uncertainty and futility in search of meaning is the kind of community that brings meaning into stories. Richard at first believed that his depression was caused by his failure as a husband and father, given the many, many hours he spent in his work. As he continued to search deeper and try to understand more of what was happening, I think he realized that the root cause of his depression was not his failed marriage, so that greatly pained him, or even the fact that he had spent so much time in his work, because he was beginning to really question whether he did that as well. It turned out that as Richard began to explore the meaning of what was happening to him, he realized that, yes, he worked very hard, but he gained pleasure out of the fact that he worked as hard as he did. He worked hard as a parent, and he gained pleasure out of what happened in his work as a parent. So he began to reform and find different types and more suitable meaning to the story that he was telling. His community helped him do this because they helped him in one way recognize that his dedication to his work, he continued to work very hard as a radiologist, worked very hard. They helped him realize that it's in this work that you're doing that you're being faithful to your religion. In other words, his religious vocation was not in knocking on doors or visiting the sick. His vocation was being the very best radiologist that he possibly could. And that brought real meaning into his life. But these stories sometimes don't have a neat, happy ending, a finality to them. I really think that our stories as individuals in general, and certainly the stories of the depressed, are what has been called never-ending stories. They go on, and we just don't know where the ending might be. Richard said, I feel better now as he had recovered from his depression. I seem to be doing better than I was before. But frankly, I don't know why this happened to me. I'm not sure I'll ever totally understand it. And that's probably exactly as it should be. Next thing. Faith communities help us to name our infirmities. The old fairy tale, Rumpelstiltskin. How many remember that fairy tale? I know that. I think most of you do. So remember what happens is that this evil little man captures the maiden, locks her up, and has her, I think, sewing straw in the gold, if I'm not mistaken. But the deal is, if she can name him, then she can escape. And so she has no idea what his name is, and finally she finds out the name. She tries a couple of names, they don't work. The third time she says, your name is Rumpelstiltskin, and he gets so angry he snaps his foot into the floor and he disappears. She escapes. Now, Fuller Torrey, well-known psychiatrist, many years ago said part of recovering from a depression or any psychiatric disorder is what he called the Rumpelstiltskin effect. That is, giving it a name. And so, if you go in and you're just feeling terrible, and the doctor says, oh, I know what's happening to you. You have all the symptoms of a major depression. That's some comfort to an individual. But what it doesn't do is it doesn't bring a complete understanding. You can go in with a pain in your abdomen and go see a surgeon, and that surgeon can tell you, I think you've got gallbladder problems. Does an ultrasound on you and says, oh yeah, you've got problems with your gallbladder. We need to get that out now. Goes into surgery 12 hours later. You come out, you're feeling fine. You've named it. I had a gallbladder problem. I had a gallbladder attack. I had my gallbladder removed. And then that's all you need to say. But depression is not that way. Naming depression is much more nuanced, and I think we need to keep that in mind. Faith communities help us to name our maladies, help us to name what's going wrong with us. And so there have been many different names that have been used. One name is the dark night of the soul, which actually is not depression, clinical depression as we understand it, but it certainly captures that you can be down and still be in the midst of your own spiritual growth. Other names have been given, the Christian life or religious life in general is a pilgrim's progress. We're fellow strugglers, such as Job. There's growth that occurs through pain. In the faith community where Richard resided, they had a name for what all of them were doing, and they talked about it as the journey. They were all on a journey. The journey could get tough, and people were at different places on the journey, but they were walking together and they would help one another. And that metaphor of a journey was just as important in naming what Richard was experiencing as labeling his problem as major depression. Now, communities sometimes, faith communities, sometimes can misname problems and don't allow names to creep in, and then they're not functioning as they should. Barbara Ehrenreich is a writer. She wrote the book Nickel and Dime. How many of you familiar with that book? So I think many of you have read that. She wrote a book more recently called Bright Side, and she just really takes on positive psychology, and she developed breast cancer, and this book derived from the fact that she was just totally put off by all the people patting her on the back and saying, everything is going to go great, everything is fine, you're not going to have any problems at all. Sometimes faith communities act that way. They don't allow you to name the issue that you have and to struggle through that issue. Rather, they kind of say, you know, get over it, or it's not as bad as you think it is. Then faith communities are not working as they should. But when faith communities faithfully name the issue, name the journey that an individual's on, then I think they are behaving as they should. Next, faith communities should teach us that there is a social psychiatry. I think we've lost our appreciation that we live in a tough world because we have become so individualistic, thinking that we are responsible for solving our own problems. We see this played out in the political arena. We see it played out at Harvard College, and I'm sure when you see people fighting to get tenure, and you know you've got to do it on your own, and nobody's going to help you, and people will compete with one another. The same thing happens at Duke, where I'm located. It's a tough world. And the idea that communities can be supportive is somewhat become lost on us. But we know from a long time of research, and David Williams is in our office, has been part of this research, that things like social support, the social environment, are all causative in terms of our mental illnesses and can be beneficial in terms of our health. In other words, it's not just on us. It's on the community as a whole to help individuals through troubled times. Faith communities can be invaluable sources of this kind of support. In addition, faith communities can, in another way, be destructive. I want to mention this also. When individuals who are suffering are isolated, maybe put into a special group, and that's, you do your thing over here, you're not really part of the group as a whole, then I don't think faith communities are being what they should be. So what happened to Richard? Richard found a lot of tangible support for his feelings within a small group that he had within his faith community, his church. And this was extremely valuable to him. In fact, he, within a fairly short period of time, began to call this group his family. And just recently, one of the members of the group lost a father in a city that was a 10-hour drive away. And Richard and his wife, and I'll come to the wife in just a moment, drove overnight to this city to attend the funeral and drove back the next night. And people asked him, Richard, why did you do that? That was crazy. In fact, the people who had lost the father said, we don't understand. We're really glad you're here, but we just don't understand why you would put yourself out. And his answer was, you're my family. Faith communities can behave like families. And I think that's a very important thing to recognize. Next, faith communities teach that hope and purpose are critical to the healing process. Depression, just by its very nature, seals off our sense of hope. We see no future. Time just seems to be blocked into the future, and that's it. Faith communities almost invariably look to the future, so there's a direct contrast between how we view things when we're depressed and how faith communities view things. And faith communities also provide, if they work well, a purpose. Why are we here? That's one of the things faith communities answers. It answers that question, why are we here? Finding a purpose. And it's not just finding a purpose individually, but it's a purpose within a larger purpose. Richard found a purpose in this faith community. He asked initially, what can I do? I've received so much. What can I do? Well, it turns out Richard is a whiz at computers. He's a whiz at doing just handyman types of jobs. And so he, given even his, hours and hours of work in secular work, every Saturday afternoon he is out working in somebody's home within our community. It's actually in our community, helping people to, put up blinds or paint a room or something like this, or if they have trouble with their computer, he will do that. If I have problems with my computer, Richard would be there to help. So he's found a purpose. It may not seem like a noble and glorious purpose, but for him, it's a purpose that gives him meaning to his life. He can do these things for other people, people that belong to his family. And finally, faith communities teach that helping those who are depressed is a family affair. Psychiatrists have increasingly found ourselves in the position of working out of context. It wasn't too many years ago that one of your Harvard psychiatrists, Robert Coles, used to talk about going out into the homes of the people he was treating. He was a child psychiatrist, and visiting with families and trying to understand the social context in which they lived. That doesn't happen anymore. That kind of orientation has virtually disappeared. Psychiatrists see a patient for a brief time within their office, and that's it. But depression doesn't work that way. To understand depression, we have to understand the person, the family, and the community, including the faith community in which the individual resides. Richard's Richard's depression was very much related to especially his faith community and workplace. We've already talked about that. During his deepest lows, he was suicidal. And it was the support from the faith community that saw him through many of these crises. But Richard had a number of other problems that derived from his depression. He could do his work, but he just really didn't know how to live a normal life until he got married. But before he got married, he was just kind of lost. What do I do with my time? His finances had gotten out of sorts. He didn't know how to answer those questions about his finances. And what his faith community supplied to him was what I like to call a life coach. This is not a therapist, it was a friend. But somebody who Richard met with on a fairly regular basis to just deal with very practical things. You know, when do you get up in the morning? How do you get up in the morning? When do you eat? Are you eating properly? Let's talk about your finances and maybe get you set up with somebody who can help you work through that. If you've even thought about getting some advice about this, is there a way that you can cut back a little bit? Do you ever have any fun? Are there ways that you just asking him questions like that on a fairly regular basis was a major benefit to Richard as he was recovering from his depression. And finally, as I mentioned, he was married a woman who was a tremendous support to him, and that really kind of helped bring him out strong. And that woman came from within this same faith community. So what I've told you is a success story. And there are many stories out there that are not successful, but I also mentioned initially that this is kind of how faith communities should work. And when faith communities work as they should, I'm convinced that faith communities have a lot to teach psychiatrists. So let me just list briefly as I finish up, and then I'm going to turn it over to John T. He's got a couple of questions and comments. Let's just go through these 7 points again. They teach us that depression is at once biological and spiritual, and you cannot, from the perspective of the patient or the individual, take that spiritual part out and put it on the shelf and say that doesn't count. They teach us psychiatrists, counselors, and patients tell stories. Faith communities are places where we can tell our stories. Faith communities teach us the meaning of depression is important, and that searching for meaning is just part of being depressed. It's not simply a disease such as gallbladder. It's about meaning. They teach us how we name depression. And depression, major depression, that's the name it's given, is part of the name, but the name probably involves more than that. They teach us that there's a place for social psychiatry or just society or people around us. Our community can be a tremendous source of support. It also can be potentially very damaging. We have to pay attention to the social environment around us. Faith communities teach us that a critical process of healing is hope and purpose. And finally, faith communities teach us that depression is a family affair. We all are involved in this. If somebody has a gallbladder attack and they go to the surgeon and they have the surgery and the surgery is successful, there's not much need for other people to provide a lot of support. But when somebody experiences a severe depression, this is sort of a call to community to help that individual through that very difficult situation. So thank you very much.
He's been practicing psychiatry for over 30 years at Harvard Medical School. He's an associate professor there. Really one of the leaders at the intersection of spirituality and mental health, and it's great to have you here.
Thank you, Mike. suffering in search of meaning, and then also later about depression and shutting off hope. I sometimes think of it, at least when it takes on a life of its own, as having a distorting effect on a person's perspective, a kind of negative meaning that needs to be confronted at some point. And I wonder if you could say a little bit about how you think religious and spiritual communities could do that, or help people with the spiritual dimension of depression without either reducing it to a chemical balance or adding to the shame and stigma that we are so aware of.
That's an excellent question. I guess the way I would start, one of my favorite books in the Bible is Job, because I think it really describes an individual who is struggling. I don't know that you could say Job was clinically depressed, or he certainly sounds depressed, but he had a lot of bad things going on with him. And there are many things that strike me about that particular book, but I think one thing that strikes me is that Job goes on asking questions, why, and does not get a very clear answer. And depression's that way. Many times you're just asking, why do I feel like this? Why? And you're not getting an answer. I think that both mental health professionals and faith communities have a responsibility to not just try to force an answer down that question and say, that's it, I don't want to hear you talking about this anymore, you're depressed, you've got a chemical imbalance, we're treating it, and that's the end of the story. Or something similar to that, where you just get back to work and get your life in order, and that's it. That doesn't work. Depression does have a life of its own, and that life looks like it has no hope. But the paradox of all of this is that almost by definition, depression improves. In fact, Martin Roth, a very famous psychiatrist in England, made the following statement. He said, where there's depression, there is hope, which seems very paradoxical, but what he meant was, when somebody's deeply depressed, you can almost be guaranteed they're going to get better at some point. And so I think both psychiatrists and faith communities, if they stick with the individual, ride out the period where they're in their deepest despair, and sometimes that may mean being in the hospital, and not feel like they have to rush to an answer for that problem, then that helps the individual kind of recognize, yes, there's hope out there. And I will often tell my patients, you will get better. I can't tell you when, and I don't know exactly how, but you are going to get better. And that seems to be something that will help, without telling them, this is the way you're going to get better, and this is when you're going to get better.
Thank you. Another question I had has to do with how mental health and spiritual care professionals can work together. The American Psychiatric Association and the Interfaith Disability Advocacy Coalition just made a partnership. It was on the front page of the Psychiatric News. The climate is changing in terms of trying to work together more. That's on a kind of macro level. Do you have any suggestions for how at the local level more of that could happen? We did talk about how religious psychiatrists might be related to this religious community or not.
That's an excellent question. As I mentioned, you'll immediately notice that I talk with a southern accent. And so I come from the South. The South is a very different place than Boston. So if you're a psychiatrist practicing in the South, in my area here in North Carolina, then you better know something about evangelical Christianity. Because that so much dominates the lives and the habits and beliefs of the individuals who you're around. So I think one initial step that can be taken is that psychiatrists, even if they're not believers themselves, even if they think this makes no sense, they've got to realize this is the environment in which my patients live. If I don't understand where they're coming from, then I'm not going to be the psychiatrist that I should be. I think that can occur by just having some conversations with people within these faith traditions, trying to understand. We psychiatrists are very quick to want to tell other people what we think they should know. I think we need to be asking, what should we know from your faith tradition that would help us to understand this? So I think to me, that's one of the biggest things, is to sort of just get it. And then asking questions, not being afraid to ask questions about an individual's spiritual life, without committing yourself that you necessarily agree with that at all, but at least showing an interest in areas that are very important to these individuals. So, as I said, you can't practice psychiatry in Durham without knowing something about evangelical Christianity. So, perfectly willing to try to answer any other questions or people who've got some comments. Yes?
First, thank you for your comments. A lot to think about. One thing that I'm struggling with at this moment is I'd like to speak about the difference between faith communities and families and how they help the patient get better, especially the presence of longer histories in families and the lack of a theology of rebirth.
Yes. That's a very good point. I think that families, many times with individuals who are depressed, the family are dysfunctional. And you said they don't have the history of rebirth, but they're in many ways dysfunctional. They not only don't understand, but they don't tolerate the suffering of an individual within the family. They may be struggling with problems of themselves. I think one thing, when a faith community works well, I don't think it could ever absolutely replace a family, but I think like in Richard's case, it actually can serve as a surrogate family in a time when the real family just is not working as it is. To carry the story of Richard a step further, really what keeps Richard going now is his marriage. I mean, it's his family. That's the only family he has. But that keeps him going. And that's probably the most important thing in his life. But the faith community served as a bridge to get him back into a somewhat healthy family situation, out of a situation that was totally unhealthy in terms of the family, and certainly did not contribute to his health at all. That may give you some sense. So I think at least faith communities can serve as a bridge, and I think they're never a true families, but I think they can approach that. Yes?
I'm curious, you gave some wonderful examples of the ways that faith communities can help inform mental health care from a medical perspective. I also see opportunities for the medical community to help inform the theologies and the sermons that we preach from our religious communities that can be harmful to people with mental health issues around, especially in the Christian tradition. If you just pray, it'll go away. If you just trust Jesus and turn to God, you'll get better without acknowledging the biological and physiological causes behind these mental health challenges. Where do you see opportunities for the medical and the faith communities to come together and collaborate on working together to delivering more effective care from both a spiritual and a medical perspective?
That's a very long task. I'll give you one sort of first step that I think is very important. It's a step actually that Michael was talking about earlier today, and we were actually talking about this together. He says from the pulpit of his church, his pastor would frequently refer to the congregation as God's hospital. And then expand on that, I suspect, by saying, we all struggle, we're all having to deal with issues, and we're here together to try to support one another as we struggle. I actually go to a seeker church that I sometimes describe facetiously as a mile wide and inch deep. And I've never heard that term used, and I suspect I never would, because there's a real premium on being optimistic from the pulpit and basically giving a positive message, because the idea is that's the way you really get people involved. And so, but I'm not sure that kind of community can be sustained, because people have very real problems. And if you don't show the individuals within your congregation that you understand and accept the fact that people have real problems, and not to just be isolated if they have a problem, then I think those communities are ultimately going to fail. And so I think that's why I like the concept of God's hospital. You know, just like in the medical community, we work in hospitals. I remember when I was in college, one of my biology professor asked me a question. He says, "What do you want to do, Dan?" And I said, "Well, I'm thinking about being a doctor." And he says, "Are you sure?" And I said, "Well, I think so." And he says, "Do you really like to be around sick people?" And that kind of struck me. And I guess none of us at one level really want to be around sick people. But if you're going to be a doctor, that's what you're going to do. You're going to be around sick people. If you're going to be a minister in a congregation, a true minister, you're going to be around sick people. And you need to acknowledge that, I think, from the pulpit. You need to acknowledge it in your behavior to others. So the idea of God's hospital, I think, to me is very important. So, yes, back in the back, and we'll come back up here.
I was interested in social psychiatry, finding out what you think are some emerging leaders and roles and next steps in that field.
Well, there's not much leadership in social psychiatry today. This is just not an interest of psychiatry. I hope that will change again. I think that term social psychiatry, if you know anything about the history of psychiatry, is probably a term that's sort of dead, and you're not going to be able to revitalize it. What I would like to see is psychiatry again talk about public health. Psychiatry virtually doesn't talk about public health at all. And so we don't try to identify things in the environment, poverty, stress in the workplace, war. All of these things that contribute to suffering that individuals experience, prejudice. We could go on a long list. Psychiatry has an incredible lack of interest in those topics at the present time. And I think the way back to social psychiatry is really through this public health book, because in some ways, psychiatry in 2014 is one of the least interested specialties in public health. Medicine is far more interested in public health issues than psychiatry. And I think that should be an embarrassment, because so much of the psychiatric ills that we see experienced are experienced because of things that are occurring in the environment. And so I think getting a public health perspective again is probably the route back. So right here.
So thank you also so much for your words. And you spoke a lot about faith communities as being able to offer some support in areas that psychiatry is not. And I'm wondering, a lot of people don't have faith communities and are not going to. And so I'm wondering what you think about the role of a chaplain or some other kind of community. Like, what are other ways in which these wonderful traits that you talk about, narrative, names, etc., might be brought to a patient who does not have a faith community and never will?
Well, I think, for example, you mentioned chaplains. And I think even if you have no faith, sometimes patients within hospitals welcome chaplain visits. And if the chaplain is skilled in her or his work, I think that can start things along a very supportive area. And I'm not at all saying that other communities can't be supported. I think you could take elements from each of these things that I talked about and suggest that you could find that in a good bar. Remember, Cheers, everybody knows your name. I mean, so there are certainly elements of what I've been talking about that you can transfer to other areas. I guess I'm prejudiced in the sense that I think if they work well, faith communities are perhaps in the best position to offer this, but it's not that they're the only position to do it. And so we need to be looking, I think for someone who does not have, as a physician, someone who does not have that or wishes to have a faith community, we try to look for that elsewhere. And one way might be, a person says, I just don't feel like doing anything. You might say, well, you used to play golf one day a week. I said, go play golf. Just go play golf. Be with the guys again and let's just see how that goes. So I think there are other areas where you can gain some of these. But I really do believe that faith communities are in a very advantageous position to be able to deliver this kind of support and care. Another question? Comment? Yes?
I was just wondering about what you thought of how to change the fee structure, perhaps, to promote psychiatric interest in public health.
Well, that is a question beyond my expertise, and I suspect beyond the expertise of the federal government as well. We seem to be going in the opposite direction. And right now, many psychiatric visits are 15 minutes. They're basically medication checks. And I think if people took the long view, they would see that more time with a physician who understands the bigger picture can go a long way toward alleviating and perhaps preventing difficulties that are experienced in the people when they get out. So maybe some of the revolving door kind of activities that we see within the healthcare profession can be stopped. But that's really beyond me. I mean, I think right now, the point I would make is, from the perspective of a faith community, one thing that community should do is recognize the limitations of our healthcare providers. Don't demonize them because they don't spend enough time and they don't seem to always understand. But rather recognize the fact that they're under tremendous pressure, and that's sort of where the faith community has an opportunity to step in. Any other questions? I know we're getting near the end of our hour. Well, listen, thank you very much for your attention, for inviting me here. It's been great. Thank you.